Good morning, everyone. I'm Dr. Priyanka Kapoor. I am an MDiS in orthodontics from All India Institute of Medical Sciences, New Delhi. I'm currently professor and in charge orthodontics in Faculty of Dentistry, Jamia Millia Islamia, again, New Delhi. And the topic for today's presentation is obstructive sleep apnea, changing paradigms and fading lines. Well, at the onset, I would really like to say that I'm honored and it's a pleasure to be at the 76th Raising Day organized by AFDC New Delhi. And I'm really thankful and my heartiest gratitude to the organizers for giving me this opportunity today to be a part of this August program. And, why obstructive sleep apnea? That can be another thought. But yes, anything that I present here is totally based on my practical experience of working in this field for many years now. And I certainly agree that whatever I've done in this field is not exhaustive and it's not complete. Nevertheless, it can give us some thoughts or some ideas where we can work together, we can work as a team to take this field, take it seriously and explore various aspects of this field. And I've taken due consent from my patients because whatever photographs and radiographs I'll be using, they'll be of my own patients. So due consent has already been taken. So the contents of this lecture would be primarily what is OSA. We have to know its importance and what is the diagnostic dilemma in OSA. The practical experiences in OSA for me are primarily an evidence-based approach, learning about craniofacial disharmonies which can lead to obstructive sleep apnea, then a customized mobile application tool which we developed for diagnosing or screening obstructive sleep apnea, also other aspects of obstructive sleep apnea like oral microbiome or preliminary studies on artificial intelligence in obstructive sleep apnea and the future scope. Well, I think I should not say, but whenever a bad news, it flashes on the news or on the TV, it doesn't give you a good feeling. And not late, but Papi Lahiri's death was flashed quite often in the news, and it was documented as due to obstructive sleep apnea. So I think it's high time we realize its importance and what is obstructive sleep apnea. We need to understand it is primarily connected to the number of episodes of apnea and hypoapnea which happen during sleep. And we all know, when we lie down, the tongue falls back and the upper airway is kind of compressed. And there are various, and to the degree to which it is compressed determines the apnea hypoapnea index. And depending on 0 to 15, 15 to 30 or greater than 30, it will be diagnosed as mild, moderate or severe apnea. And it is very important to classify the apnea in these terms. And then why it becomes important for us, because these pictures that you see, they are very regular in Delhi. Right now, for 2-3 days, you may have good, you may have a good vision, and you may feel nice that there is less pollution. But WHO has given a certification that the pollution levels in Delhi are in severe plus category. It's 100 times more than what has been recommended by WHO. And that leads to, it's closely linked to obstructive sleep apnea and lung diseases. There are serious neurocognitive, cardiovascular, behavioral, so many other comorbidities attached to it. And yes, there's so many truck drivers, that they cause accidents. We've seen many a times. And sometimes we unintentionally we link it to maybe drink and drive. But there's so many cases which go undiagnosed and they happen due to obstructive sleep apnea. Yes, there is excessive sleepiness, there is decreased quality of life. And in children, there is a plethora of other morbidities that can happen. They can have high incidence of nocturnal enuresis, which is bedwetting at night, and the child is very conscious. He is not ready to tell his parents, and even if the parents come to know, they are not ready to come out and open and get it diagnosed why it is happening. Then his academic grades can start falling, but we don't relate it to obstructive sleep apnea, but it's highly correlated. I have given you, as I said, that whatever I speak, it will be with certain amount of evidence. And these are our own studies which has happened. And these have been conducted in AIIMS Bhopal, and they have diagnosed a huge prevalence of obstructive sleep apnea, not only worldwide, but in Indian children that they have diagnosed. And yes, they have also associated it to the poor academic performance and to the nocturnal ureasis, as I was talking about. Worldwide prevalence is 936 million adults, and the prevalence of OSA in India in children, if you see, is 2 to 4% and 9% and 4%, respectively, in males and females. Yes, it is definitely more, maybe double in males. There are so many complications. I've already told you. You can have hypertension, stroke, ischemic heart disease, lung cancer, diabetes, deep vein thrombosis. These are comorbidities that should keep us thinking that whatever our body is trying to tell us, we should understand the basic pathophysiology behind it, and we should go after the basic pathophysiology which is causing these diseases, and not just treat the symptoms. And yes, there's so many risk factors which are just rampant in front of us, but we are not ready to recognize it. Very simple example. There's so many times that people can tell you snoring. It's just so common in India. You can see children, you can see people snoring in metros, you can see people snoring in buses and trains. And for us, it's a very normal thing, that they're snoring. We'll just make fun of it. But no, it's not normal. We need to understand it's not normal. You see our grandparents, our older, who are there in the family, they're sleeping on the chairs. And sometimes people can, or teachers can complain that your child's grades are falling, or, they are having some behavioral issues. They are having attention deficit disorders. They are not ready to sit at one place. Do we ever sit and think, okay, why is this happening? Yes, there's so many risk factors involved in it. And these are all symptoms of obstructive sleep apnea. Obesity, as we all know, is a global epidemic. The abdomen circumference, the neck circumference, that is a huge red flag of diagnosing obstructive sleep apnea. The other red flags can be diabetes, increasing age, even the sex. If it's a male, they have more probability, the central fat distribution, and yes, the neck circumference, which has a larger girth, will quite possible, it will be related to obstructive sleep apnea. And yes, I put it in red because this is one thing which is closely related to dentists. And this is where we come into picture, where we can diagnose this particular condition at a very early stage, because it is craniofacial and upper airway abnormalities, which we can see not only on the visual examination, not only in the profile examination, not only in the photographs, but in the radiographs, in the lateral cephalograms, in the intraoral parameters. Everywhere it is visible. It is just that we need to understand its importance and realize what all we have to examine to come to the conclusion that yes, this patient may be suffering from obstructive sleep apnea risk, and we have to send him for further diagnosis, or maybe treat him at a very early stage so that even the risk factor goes away. So, as I said that, the first practical experience that I had towards obstructive sleep apnea was an evidence-based systematic review and meta-analysis that we did as a team back in 2017. It got published in Sleep Medicine Reviews. It has a huge readership and citations across 300, and it's a very high impact factor journal of 11.4. Definitely, we found some basic evidence regarding the craniofacial abnormalities that are associated with obstructive sleep apnea. And there was a strong evidence for reduced pharyngeal airway space, inferiorly placed hyoid bone, and increased anterior facial heights, which were associated to obstructive sleep apnea. So yes, we come into picture, and that's where we decided that let's take this thing further into practical exposure and into the original studies that we planned for. The only problem with obstructive sleep apnea is because the symptoms are happening at night, sometimes the parents are not aware, even the children are not aware. And even if it's a spouse, you may not take it that seriously. The patient is getting up at night, the patient is snoring, patient is not able to sometimes breathe, and he's restless during sleep, but we don't take it seriously because these symptoms are mostly happening at night. And the gold standard for its diagnosis is polysomnography. It is not usually present in our own setups in primary healthcare centers, even in tertiary healthcare centers. Many times it's not available. It's a costly machine, it's technique sensitive, and yes, there's difficulty in availability. So we have certain alternatives for risk assessment, We have some screening questionnaires like Berlin questionnaire, stop bank questionnaire, stop questionnaire, modified stop bank questionnaire, Epworth sleepiness scale, pediatric sleep questionnaires. These are all standardized questionnaires which have been translated sometimes into different languages, into different countries, and they have been used for assessment of obstructive sleep apnea risk. And especially in children, it has been used so extensively to publish the incidence of obstructive sleep apnea in children. And so we decided, as we said, that when we realized that there's an importance of craniofacial abnormality examination for obstructive sleep apnea, we took this funded ICMR project of screening of obstructive sleep apnea risk in adolescent orthodontic population and correlated with the craniofacial and upper airway morphology. And for this, we used the modified stop bank questionnaire, primarily because we studied a lot of literature and it showed that it had high sensitivity and specificity in adolescent population, which was our area of interest into 10 to 19-year-old population that we were considering. And we compared the OSA risk and non-risk patients for their craniofacial parameters, both intraoral and extraoral, and also for the cephalometric and the upper airway morphology. This was a kind of chart that we had made for each patient, and the values were written and then they were statistically compared. You can see that there are parameters for extraoral examination, intraoral examination, and the craniofacial parameters based on lateral cephalometrics. So yes, then we statistically analyzed it and we found very encouraging results because the higher convex profile had an odds ratio of 7.2. It was highly correlated to obstructive sleep apnea risk. Another was steep mandibular plane angle, which was causing the increased anterofacial height. Type 3 and type 4 focal pillars, Mallampati classification also told us that the odds ratio was quite high. The ovoid upper arch class 2 molar relationship and the cephalometric variables again pointing to the skeletal class 2 and the increased mandibular plane angle, and the PNS 81 and 82, which points to the pharyngeal airway space. So we got very encouraging results. So when you get such encouraging results, that would make you work more and more in this direction. It would not stop you from achieving better results. So yes, the conclusions drawn were that the dental and skeletal malocclusions were correlated to OSA risk. That has also been given in NOSA guidelines, which was a consensus and evidence-based guidelines in the Indian Initiative for Obstructive Sleep Apnea that was published in collaboration with AIMS in 2014. And yes, it kind of potentiated those results, but the modified stop bank questionnaire was for the first time used in Indian population. Yes, it was applicable in Delhi population. The prevalence of OSA risk in orthodontic adolescents was found to be 14%. So it was huge. And ever since that day, we have been practically doing this questionnaire for all our patients who enter our clinics, whether they are class 2 or not. We do it for every patient because you never know who falls into the OSA risk. And these are kind of young adults who are coming to us. And if we diagnose them very early, we can really help them. And this study got published in the year 2020 along with my student. So I've put up this reference also. Then, as I said, that when it gives you encouraging results, you would not stop there. And then COVID came. So now what to do, because the patients were not entering the clinic. So how would we diagnose them? So we decided to create a self-determining mobile application, customized mobile application. We had done a lot of studies on obstructive sleep apnea, and we were well aware that if we kind of use the standardized questionnaires like the modified stop bank questionnaire or the pediatric sleep questionnaire, we can diagnose the obstructive sleep apnea in all the age groups, because one questionnaire is not applicable to all the age groups. And so this is the customized application based on our needs analysis. Needs analysis was that 14% was that high prevalence of obstructive sleep apnea that we found in our clinics. And so we decided that we would take different interfaces, where in one interface, we will introduce obstructive sleep apnea. We will introduce what kind of comorbidities it can cause. And then the patient would feed his own demographic data and would feed his own age. According to the age, he would be directed to the right questions. And then as he fills the questions, there would be scoring. And we divided, we kind of, validated this mobile application. Again, when we joined back in our clinics, we used it in the hospital-based population. And so that is when we kind of validated this mobile application also. And we got an award in Orthodontic Innovation Conclave in the year 2021. And this was the flowchart that we followed for the obstructive sleep apnea risk assessment tool. We called it that, and the customized mobile application was called OSA risk assessment tool. So first of all, we did the pilot project, then we did the interface designing, then we did the usability inspection, then we did the validation, and then the pilot study sample was done on 100 adults and 100 children, and we got very encouraging results. And based on the scoring, they were diagnosed. The kind of questionnaire that was being used, whether it is top band or PSQ, it gave you a scoring of risk or non-risk. And based on that, there were suggestions made of using the preventive modules or orthodontic interventions or referrals to other sleep clinics or ENT specialists. So these are the, again, the evidence that we produced and we got published. And this is very recent. It got published in 2022. And the development testing of the mobile application was published again in the year 2022. So you're most welcome to go through these publications. And then, because it was used so extensively now in our clinics, we try to extend and diversify our interest in obstructive sleep apnea, because oral microbiome, as we all know, it determines an area of hemostasis in our own oral microenvironments. So if there is any dysbiosis, it leads to a lot of, it can give you information of a lot of biological processes that are happening inside the body. And obstructive sleep apnea is one amongst them. So now we planned a study, and we also got an iOS RF grant for it in the year 2020 on oral microbiome in orthodontic patients with obstructive sleep apnea risk using flow cytometry. The sample size calculation was 10 in each group, in OSA and non-OSA. And then we used a mobile-based, like the OSA risk assessment tool we used for diagnosis of these patients, because again, 10 to 19-year-old were used. And then we did the microbiome assessment for risk and controls. Why we used microbiomes? Because, as I already said, that the area of dysbiosis that is produced in the oral microenvironments can give you huge information of various kind of systemic and the oral diseases which are happening, maybe periodontitis, endocarditis, atherosclerosis, Alzheimer's, diabetes, head and neck cancer. And yes, obstructive sleep apnea is one of the pathophysiologies that we really need to understand, and how it's correlated with all these diseases. So, as I said, that we tried to obtain the oral microbiome using the swab samples, and these swab samples were taken from 6 sites. I've used it diagrammatic representation, and this had already only been used in one study in obstructive sleep apnea before that, and it was in adults. So we used the same sites, and the observation time was immediately after we started with the functional appliance treatment. So these were young patients, and we were treating them for functional appliances. So we tried to take these swab samples, and the collection was by sterile cotton swabs, 5 millimeter in diameter. So it was standardized. And yes, we had the facilities for obstructive sleep apnea and also for pre-processing of these samples, which was done in our own biosciences department. And the equipment was also available there. The results in the flow cytogram by the forward scattering and the side scattering, it showed us, it gave you a huge amount of information on the total abundance of the oral microbiome. And the results showed that the control samples had significantly higher counts compared to OSA risk patients in non-risk patients, suggesting that the bacteria significantly reduced in OSA risk patients. But this was just the relative abundance. We did not have the absolute abundance, because when we started doing the study, we found out that for the absolute abundance, we needed to take another approach, which was for a microbead approach. And yes, in the further studies, we want to do that. But still, we got a lot of information, because we know that the dysbiosis that is happening in this case is leading to a loss of the various flora, the bacterial flora, which is present in the oral environments. And severe apnea showed 31% positive values, while those with the moderate values. So even in moderate and severe, you could identify the difference. But yes, the abundance decreased with mild to severe apnea risk. But no difference was noted in the 6 sites that we had examined. This study is still in the publication stage, so I have not put any publication in this. Then another thing that we needed to know when we studied about microbiome is that the distribution and the abundance, they're 2 different things. So with the 6 sites, we wanted to study the distribution, but with the abundance, we wanted to know that if the abundance is different in risk and non-risk. What are the implications of it? Why would we want to study that? Because we need to know the pathogenesis of this. Are there any correlations with other respiratory and oral conditions? If we know the taxonomy also, we can study the parallelism or some overlap with the other respiratory and the heart conditions also. We can personalize the oral hygiene measures. We can use the fluorescent beads, as I said, for the absolute abundance. We can use the 16-hour DNA sequencing for microbial diversity to study the correlation with other severe comorbidities and associated conditions. So yes, there's so many huge implications. So whenever you do a study, or whenever we do a study, we this is just one study, one step that we take, and then it opens up doors in various directions. So these are the directions that we kind of list with every study that we do. So for this study, definitely I feel that it has opened up Pandora's box, and we would really like to go in certain of these directions, and we've started working in 16-hour DNA sequencing as yet. Then there was another aspect that we tried to explore, that was in artificial intelligence for facial and radiographic markers for obstructive sleep apnea. Well, since we had now for 2 years now, we have been collecting the records for radiographs and the extraoral photographs, which is frontal and lateral, for all the obstructive sleep apnea risk and non-risk patients which report to our clinic. And so we had this data available with us, although it was not huge, because for any artificial intelligence, you need a minimum of 1,000 samples. And for this, I'm here for, if anybody wants to join hands and collaborate with us, we would be really happy, because we are still kind of building up this data. And we have some preliminary results. We are using the deep learning models developed in Python using the TensorFlow library. And so we have done some preliminary studies in this aspect, and these were the results that we got. We kind of created 3 models, not we, but yes, our computer engineering department, who are in collaboration with us for this particular study. So we have model 1, which is combined facial photographs and radiographs, model 2, only facial photographs, and model 3 with only radiographs. So yes, this is a preliminary study, and we are going ahead with it. And sincere request, if any of you want to collaborate with us on this, it would be really, really wonderful. So what more we can do, Wes? Well, I think that I have kind of given a brief overview of whatever we have done practically in this particular measure of obstructive sleep apnea, but there's so much to do still at a societal and a public health level. And yes, questionnaire-based screening, I strongly recommend for all the primary health centers, for schools, for old age homes, for road traffic authorities. Please do not give license to obstructive sleep apnea, to severe apnea patients, pediatrician clinics, government dental and medical hospitals. We can formalize some norms at the public health level. We can take them to higher authorities, so that we can have a perspective where this assessment can be the preliminary assessment for further doors to open. Awareness in school, teachers, physicians, dental surgeons regarding predisposing factors, very, very important. If you see a child snoring in your class, if you see a child with ADHD, which is attention deficit disorder, if you see a child whose grades are falling or is complaining of bedwetting, please think once that it may be obstructive sleep apnea. Have these questionnaires ready with you. Training of dental and orthodontic clinics for the getting the mandible forward with simple oral appliances like the functional appliances, that can also make a huge difference if it is given at the right time, at the right age, and to the right person. Undergraduate curriculum changes should definitely involve obstructive sleep apnea, because our thought should once go to this particular condition. If we are not trained in that, we would never like to look for symptoms for that. And yes, this is my end slide, that we have to look for children. I'm really, really concerned, because that is one area where we can really target it very easily. So nocturnal enuresis and academic performance, I strongly recommend we should follow that up as parents, and we should also tell the school teachers to follow it up. Use of artificial intelligence, we have started with the preliminary studies, but yes, we need more and more aspects, more and more data to train our machine learning models. Mobile application, simple mobile application as we've made, it can be used for screening. we can look for other facial markers also and incorporate them in the further versions of mobile applications to come. So yes, this brings me an end to my lecture, and I do hope that I've kind of, tweaked your interest in this particular direction, which maybe till now the thought didn't go in this direction. So it will be an honor and a pleasure for me if I get some queries from your side and some inputs from your side to improve our research and the areas in which we are working in obstructive sleep apnea. I'm here to join for collaborations and work together. These are my references. And this is a workshop that we are about to conduct on 6th of October at NAMSCON Bangalore. You're most welcome to be a part of it. Again, it will be an honor and a pleasure. And this is my mail ID. If you have any queries, any suggestions, any comments, I would be really, again, I'll be really honored. Thank you so much again for this opportunity. And with this, I come to the end of my lecture. Thank you.